And we can see that Date is already, he is eager to show his case. Date, thanks for coming, and it's a privilege to have you here. Thanks.
Same as to you. Thank you for inviting me. It's the privilege and it's an honor to be here. And special thanks for hospitality for my young colleagues. I think that they found it useful for them too. And this is the case, no pain, no gain, with a big question mark. And this is the first time that I have a complex case, not the complication in this session. So you said that these are the notes for the session. In progress of planning, discussion of procedural steps treated successfully with happy ends to be continued, and I tried to put them all in the one my case. In the background, I think it's first good to say that the case is 6 years old when I performed my practice in a small general hospital. And this is, at that time, this is my annual volume, about 170 PCIs. Most of them are in acute coronary syndrome. And there is no cardiac surgery on site, no circulatory support, no imaging, and of course, no rotablation or another techniques to modification of the calcification. And this is the patient, 68-old, and high-risk non-STEMI, presented with chest pain during the hemodialysis and with dynamic ST changes in inferior leads. He is diabetic. And this is the left coronary. You can see it. And this is the right. It doesn't work. This, sorry. And this is the right. So the question for the panelists: what would you do? PCI of the culprit lesion with PCI of the left coronary during the same hospitalization. Number 2, complete PCI revascularization during the initial procedure. PCI of culprit lesion in cabbage later, and send to the cabbage immediately. Please vote.
You have a syntax?
Yes, later.
Later on. The
Quick decision.
No, the
during
troponin?
On the table.
No. ST elevation?
No, depression.
Troponin?
In inferior leads.
Troponin?
Troponin high. But he's on hemodialysis, but acute typical chest pain with ST. And immediately in the cath lab.
I presented yesterday a slide with telling that staging is saving life. So staging is not a mistake, for sure.
Okay.
So if you feel it's difficult, you stage. So you do the right first and the left after that.
But I'm pretty sure that majority of interventionalists, especially in my country, who are paid by the cases, they would do right and waiting for the assessment of left.
Yeah, same.
Okay,
I'm
that's
only one for
exactly.
cabbage.
You will
PCI
send
and cabbage.
Anybody? PCI and cabbage.
No, but let's say something clear. According to the guidelines, this patient is without ST elevation. If he is stable and nothing urgent, we should discuss him in the heart team, and he is probably is indicated for cabbage. Do we agree for?
No.
Sure.
According to the guidelines of acute coronary syndrome, without ST elevation, we are free to resolve the acute problem, the acute lesion,
yeah.
and then we should discuss with surgeons what to do next. This is according to the guidelines.
Yes,
The
but what is the acute problem here?
If you put the stent in the right and then you discuss with the surgeon, you won't be happy, you know.
I have only 15 minutes and I have a lot of questions for you, so move on.
You need to aspirate blood.
This is what I find in the guidelines. This is what I find in the guidelines for revascularization after I decided what to do. For diabetes, he is diabetic on hemodialysis with acute coronary syndromes. There is no randomized studies, but they suggest to go to the CABG. And end-stage renal disease on hemodialysis, again, no randomized studies, but registry is really huge, 22,000 of people, and the data go to the CABG. But of course, I didn't do that.
Of course.
I was on the table and I decided to
Because you believe in the culprit.
Culprit lesion.
Yeah, exactly.
This is a multivessel disease, so syntax is not enough. Syntax 2?
This is the process of thinking after that.
Fix it.
And again, I was studying the procedure on the left, and this is what we will discuss on the cardiac heart team. We don't have cardiac surgery, but I have online my friends of cardiac surgery 200 kilometers far. And I decided to prepare for this case with these questions. Anatomical complexity, syntax is 20, and there are the same results for CABG and PCI. Syntax 2, including clinical variables, same. Surgical predicted mortality with 2 scores, acceptable. And the completeness of revascularization should be done with PCI, of course. So these are the guidelines. So we can discuss, is it at the moment 2 vessel disease, maybe 3 vessel disease, is it left main or not? But with diabetes, they will say, send the patient to the cardiac surgery. And especially for the hemodialysis patients. We should choose, again, CABG. But, first of all, what will you do? Panel.
CABG.
PCI.
We forgot a very important part of the equation, the patient preference.
Yes, and that's the very good point. Patient information patients should be included and very discussed, unbiased, evidence-based, up-to-date, acceptable, relevant data. He must have time to think, and this is also important. You should inform me about how are you doing that very good? What's your performance? Do you have everything that I need for this lesion? And I thought that I should send him to the CABG and that he deserves better than PCI in a small hospital without rota and possible complications. So he refused. And he said, I believe in you. You have done this lesion. You perform 1 per month left main. What do you think? Do you have the feeling, as Yves said, I can manage it?
Yeah.
So what will you do now?
You have different kind of complexity. Well, I'll just have a look at the coronary angiography. For me, it's not so complex.
Of course.
we
No,
saw
it's not
only one projection.
This is because you have to
Yes,
make technical
of
This
course.
choice.
is
There's
very tricky point which Deity just left to us, because up to now we saw only one projection from the left coronary
Yeah,
artery
yeah.
Yes, I don't
with
have
a quadriforcation.
We'll see.
The most
see, but,
important.
Not trifurcation, it is quadriforcation.
Quadri, okay. So,
And it is no, because left main,
I
it is
said-
a sure left main, it is osteoaroides.
I said to me, no pain, no gain. I'll do it. I have the feeling that I can do it. So I will show my muscles. But I was thinking maybe this is my real picture. And procedural steps. I'll skip it here. I'll try to be short. I think this is trifurcation. I don't see the
Fourth vessel.
only what I'm worrying is calcification of LAD. And I don't want to lose any branch. So I decided to go to femoral, huge catheter, and to decide to take any complication in procedure planning. So if I have to do aggressive optimal predilatation, especially of LAD, and then of CERC, with scoring balloons, 1-to-1 ratio, and then I will decide. If I have a rupture, the rescue plan is if I have the section or acute close of LAD, I will put provisional stenting of LAD. If it's in CERC, then I'll do the double kissing crash. But if everything goes good, I will keep it short, simple, safe, and my fellow say stupid. Keep it short, simple, safe means I will put the drug coating balloon in a CERC and do the provisional left main. But if I have any complication, I'll do something you will saw. If that's happened, it's 4 kissing crash. So the patient was treated successfully. That's the point for the first time. I will skip the predilatation, but you have to believe me that I was, it was probably B dissection, but I don't have the IVUS. And I decided I will put a stent in the CERC, 3 wires, balloon non-compliant in the intermedial branch, expansion of the stent, first rewiring, first kissing. I want to put the new carina between intermediate and CERC. And then stent in LAD, pot with huge balloon, and then secondary wiring, keeping the wire in LAD, and then I have the troubles crossing I want to spare material, and I was pushing unused non-compliant balloon, and then there is, if you are the master of it, longitudinal distortion of the ostium by catheter, but pushing, that I fixed with a pot, and then exchange with 3 balloons, and making new 2 carina. First kissing, second kissing, and tracing for 3 times. And final pot. And this is the result. It looks good.
Superb.
Is this the happy ending? No, it wasn't. No.
No.
15 months later,
This is the procedure of success, but we should see the clinical.
And last question, what do you expect after 15 months with this technique that I
How
think
long?
it's something
3 months.
15
Ah,
Osteal lesion of the left
We
main.
have
Yeah.
two stents, one crushed in
Left
third,
main osteal lesion.
maybe two carina, I don't know where the wires were going. Tracing, so calcified lesion that I worried about, with no rota. What do you
us.
expect?
Show us.
Everything.
What we will find in
Please
this
show us.
angio, last angio?
Excellent result.
Osteoid.
I would expect excellent result.
Left main.
Excellent. No,
Okay,
he's,
we-
he has a stable angina.
we
Osteo left main.
already numbered all the lesions, so let's see who is the
Show us.
You
right.
never know.
Where is the culprit lesion? What do you think? Main? Left main? Anybody?
Osteoid.
Osteal left main.
LED?
Everywhere.
Calcified?
Okay. Everywhere. Right.
Show.
Right.
I have
Right coronary.
right, of course.
Right.
But no. This is the result. And
osteocircumference.
patient goes to the cabbage and he's well now. So my
There
final
was a new
thoughts are
lesion in
that
there.
complex interventions requires complex decisions. In patient-centered shared decision-making process with high team, of course. We have guidelines, we have risk calculators, appropriate use criteria to help us, but quality of the clinical evidence is just of many factors, and frequently it's not the most important one. We have to make our own decision in everyday work. And we will use a lot of combination of what was said, but please take into account objective your own capabilities, skills, experience, and overall performance. Thank you.
Thank you, Dayton.
I have a comment. First, technically, you were able to do these things, which was not so difficult. Was not difficult. No? But for you, was it difficult? For a beginner, it would have been difficult, but for you, was not difficult.
Yeah.
So the problem of this, what occurs 15 months later, is not related to the quality of the operator. I would have done something completely different. I never stand the side punch first, never. I think the problem is there.
I decided not to stand it. I decided first intention was maybe I should keep it, accept dissection. The Cortese has a published paper, even C-type dissections could be healed spontaneously, especially if you put the drug coating balloon. So,
and you know, also,
simple
majority of
provision
cases,
of left main.
majority of cases don't prepare the side branch. So after that, you have the discussion
But we have
where to put the
we-
first stent. No, just to say, I don't know what would have been the result of my procedure, of course. But after that, you have to choose. You stand first, crossover to circ, and crossover to LED. We call one inverted, but this is not inverted because the two vessels are the same size. So this is a crossover. Crossover to circ, crossover to LED. Regarding the anatomy of the vessel, probably I should have crossover to the circ first. Protection only for the intermediate, and probably nothing to do there. And after that, I will have exchange, prepare the LED, and do a perfect distanting, because LED is aligned with the left main. A perfect distanting, nothing on the intermediate, nothing will occur, nothing. And what I would have done. So it's different, but this is, it shows to the audience that this, if you have a strategy which is well defined, this is not a very difficult lesion. Of course, this is not the second segment of the right, but this is not very difficult. When you perform CTOs, I have seen in Valérie and me doing CTOs, this is much more complex, you know? So it's not, the problem is to define the strategy and to apply. So you did it.
Okay. But they made the predilation that, in a way, with the dissection.
Yeah, that's why I don't like to predilate the
discussing a lot of possible techniques for DCB in bifurcation. So
no, I think you did the predilation of the circ, and then your intention was to do the crossover stent.
I don't want
and
to
you change your mind because you have a dissection.
I don't want to cross the stent after the kissing left main. I don't want to lose the drug crossing the struts of the stent. That's the intention of treating
but if you stand for ostium to left main,
significant side branch first.
Two circumflex, you solve the problem. You don't prepare the LED. You use the good diameter in order not to close LED. And this is, in my opinion, this is easier and may have given a different result. I don't know, but...
Very often there is a big angle between AOD in the direction of circ. And this is, in my view, one of the problems why this restenosis is most often seen there, because in this big angle, which is sometimes more than 120 degrees, I'm sure the stance is not performed the right way.
I show a slide yesterday.
Yes. But this is something, that's why when we have such an angle, probably a good option, although not, is to have a two-stand technique, if you use it just to have a tap or a crush or something like that. Because even the keyword is, this stent is compromised because this angle is not able to be, let's say, from the material point of view, from mechanical point of view, it is not possible for a stent to follow.
Probably the shear stress is, we don't
it depends
know
not, it is the structure, and if show it very well because
the external
part
layer of the stent
it is radial
is not extending longitudinally enough, so
it is becoming like this.
The stent is not opposed, in fact.
Just remember the note of Antonio Colombo 3 years ago, maybe 3 or 4 years ago, that the only way to escape the restenosis at the ostium of the left circumflex is not to do angio.
It's always wise. And maybe into the direction of the intermediate, left main to the intermediate is an option too.
Yeah, but it's not a big vessel. Intermediate is not a big vessel.
It was bigger than circumflex.
Anyway, thanks.
Thanks a lot.
So we're continuing with the next case, which it is recorded. Yes, it seems to. At least it is, starts very promising. Can you have the?
Hello, my name is Christos Floros. I am a consultant cardiologist in second department of cardiology in the University Hospital of Ioanna under Professor Lambros Michalis, and I will show you one challenging case from our cath lab. It's about a female patient, 86-year-old, with CABG operation 2005, with Lima LAD and vein bypasses in M1 and PDA. She has known blood pressure, dyslipidemia, diabetes mellitus type 2. She has also paroxysmal atrial fibrillation with under NOAC therapy. The patient came to us with angina pectoris symptoms class 3 the last 2 months. We made an echocardiography which showed us preserved ejection fraction with hypokinesia in the inferior wall. From the labor, only mild kidney disease with negative troponin. We performed a stress echo which showed ischemia in the inferior wall. So we decided to make the coronary angiography. The native system in the left side showed us the known 70% stenosis in the left main. And the lima was good with TIMI3 flow up to the distal LAD. The right coronary artery, as we intubated the right coronary artery, we had a dampening in the pressure, which indicated a possible significant stenosis in the ostium of the right coronary artery. And you see in the distal RCA, crux cordis, one filiform 99% calcified lesion. That's another view here, where you see that the ostium has a possible relevant stenosis. The bypass in the M1 was okay with TIMI3 flow and up to the distal M1, and the vein bypass in the right coronary artery was chronically closed. So we had a patient with symptoms with angina pectoris CCS3 with a problem in the right coronary system, which was not managed from the vein bypass, which was closed. We decided, because of the age of the patient, because of the mild kidney disease, and because we thought that it would be a complex PCI, to make it in not to make this direct, but another day, and we decided to go femoral. So we used Judkins right 6 French catheter, and as we intubated the right coronary artery, we had the same problem with dampening from the blood pressure. We went fast with choice LS guide wire up to the distal PDA, and we pre-dilated the ostial lesion with semi and non-compliant balloons. We decided to go first ostial, and we used the 2 guide wire technique in order to implantate the stent exactly in the RCA ostium. That's the technique, the 2 guide wire technique. That's the stent, which you see that is exactly implanted from the proximal right coronary artery until the RCA ostium. And that's the implantation of the stent. And then we made a post-dilatation with a 4.0 balloon, NC balloon, and that's the result in the RCA ostium. Then we went distally. The lesion was more calcified and more tricky as we thought, so that we should start with 1.5 balloon, as you see here with the central marker. Then it was difficult this to open. We had we wanted more lesion preparation, and in order to break the balloons, the 2.0 NC balloon down in the RCA, we should make an escalation. The escalation was between second guide wire versus guide extension. We decided for a second guide wire, and finally we successfully pre-dilated with a 2.5 NC balloon the distal RCA. And now the final step, the drug-eluting stent implantation. As we tried to bring down the stent, we had many problems in order to bring this down. And in order to escalate to a guide wire extension, we pulled the stent back. And what happened was that the stent the stent balloon, the stent stuck in the previous RCA ostium stent. Now, why did this happen? This happened because possibly the stent strategies were a little bit deformed as we tried to bring the stent down. And now we should manage with this complication. It was a little bit difficult to bring the stent balloon out of the right coronary artery, and with many maneuvers we made this, and you see now that the balloon is coming out. And then the next step was to see how the flow in the right coronary artery was. The patient had a little bit angina pectoris, but she was stable. Then the next step, what we decided to do is to reintubate the right coronary artery and to bring a new guide wire up to the distal RCA. That was very difficult at the end, and with many maneuvers and techniques, we finally succeeded to intubate the artery and to bring a guide wire under. And now you see another guide wire. And what can one here see is that the second stent, which was stuck in the RCA ostium stent, is flailing a little bit in the aorta. So our decision was to crush the stuck stent in the first RCA ostium stent with many balloons. We started with 1.5 balloon up to 4. That's a 2.0 balloon, and then we made this up to 4.0 balloon. Then we used the guide extension in order to prepare another one more time the distal lesion. We made many pre-dilations with semi and non-compliant balloons, and finally we succeeded to bring the stent down, and we implanted the stent approximately in the distal lesion. We made also a post-dilatation with C balloon with 2.75 20 balloon, and that's the result which you here see. Ostial and distally we are okay, but are we generally okay? That's the question. If someone sees better the whole vessel, one can see that in the medial RCA we have a dissection. That's probably because of the use of the guide extension. And then we prepared the lesion one more, and we implanted another stent. Here you see how we did this, and that's the final result from two angles: proximally, ostially, medial, and distally. We made, of course, an IVOS, which you here can see ostial. Here you see the crushed stent at 6 o'clock, and then at 7 or 8 o'clock comes the flailing part of the stent in the aorta. So the patient was stable in the whole procedure, and then we brought the patient in order to monitoring in our intermediate care station. We decided because of the PAF with high SATS-VAS score, and because we have a part of the stent in the aorta to make a triple therapy with aspirin, clopidogrel, and NOAC for 3 months with regular measurement from hemoglobin, and then double therapy with clopidogrel and NOAC for at least 6 months. We made also a control coronary angiography from the patient, and we see that the whole stents, the 3 stents in the RCA are very good. So our learning points from this challenging PCI is that it's too important, the good preparation and planning before any procedure, and by every procedure, and when the procedure when one thinks that the procedure is difficult, one should have more thoughts and plan good before the procedure. Fast upgrade, either with second guide wire or better with guide extension. One, as interventional cardiologists, should see and manage the complication, and at the end, always look the whole vessel and not only the standard part of the vessel. Thank you very much for.
Is connected?
No. Do you have a connection with Christos?
Hello.
Hello. Thank you for the case, and really compliments. Now we are going to discuss the case. Some questions, comments from the panel. Robert?
Once more, thank you very much for this presentation. It was very honest from your side, showing us everything. But what I really missed in your, let's say, conclusions, there are 2 additional remarks. The first, never start to stent with proximal, since you have to deal with the distal one. This is a crucial rule which should be taken into account since the beginning. The only difference is, as yesterday Yves mentioned, that when you have very diseased long vessel, when you have already prepared the lesion, and then you can are able to avoid, let's say, too long stented segment, then you can start from proximal. But you have to be sure about the easiness of delivery. Otherwise, you know, this distal lesion was calcified. Even proposed to ablate with rota, just to facilitate the procedure. And the second remark that I would like to put in your conclusions, if you are able to do IVUS, do that procedurally, because then you can make a good plan to shorten the procedure and to optimize at the end. This is a big mistake to use the IVUS just at the end to assess whether it's optimal or not optimal. It's a wasting of time and a lot of material in the previous phase of the procedure. But anyway, you succeeded, so congratulations.
You're absolutely right in both your remarks. Mostly we are making distal first is the first lesson one takes when one starts to be an interventional cardiologist. In this case, we discussed during the PCI what would we make first, and we decided, because of the dampening of the blood pressure, to PCI, to put the stent first ostially. Sadly, it brought more problems as solutions. And of course, the second point that you made, Yeah, IVUS. We used IVUS. We used also during the PCI, which I didn't show, but we thought that we underestimated a little bit the calcification in the middle of the RCA. I must be honest.
I'm just wondering if there was a need for ROTA after stenting ostium of the right coronary, how it would be dealt with.
It can be done.
Yes, it can be done. We can. You can
course
make
it
a
is
guide
increasing
extension just
but you can go,
to do
if you-
so. But
I mean, if you predilate well the proximal part, you can go with the bird beyond the stent and after that start. But still, it is a challenging procedure.
You have to be very coaxial in order not to hear the special music.
Special
I'm not
music.
so enthusiastic to do rotablation through the freshly implanted stent.
It's very risky, this is for sure. You have to use very deep position of guide extension catheter.
Yeah.
This is the only way.
Yes.
This is the only
Oh,
way.
you can put.
I remember that Tomek Pawlowski demonstrated exactly such a case with the guide extension, with the deep intubation of the right coronary in WCCI 1 year or 2 years ago.
This is not. I mean, you can put a guiding catheter extension and a burr 1.25 can go. This is what you can do in the left main, just to preserve one wire. But of course, it is something which is to preserve the two wires, not to leave the unprotected the circ. But of course, it's excellent. The first conclusion is plan the procedure well in advance. And what we should always do is prepare for the worst case scenario and plan it according to this.
But we used to underestimate the problems.
Yes. But this is, nothing human is 100%. This is true.
99% of the problems come from the planning.
So we're moving to the next case. When a door closes. This is Dr. Matei.
Dr. Matei.
Chris, and thanks for being with us.
Thank you for the invitation. It's a pleasure. An honor.
It's a very nice gate.
So my case has something in common with the first case that Dr. Pervulovic presented. Actually, as you can see, I'm a young interventionist, but a senior in the city where I come from, in Iași, in Romania. We've opened a cath lab 2 years ago. We're a team of young doctors, and we're trying to do what we can for the good of the patients with the little experience that we have. So I think everyone knows this saying that when one door closes, there's another one that will open. If you want to be poetic, or say, God will open another one for you. Well, in Romania, we're more practical. Actually, we say that when a door closes, you have to enter by the window. So let's see what the case is about. This is a lady, a 76-year-old lady who presented for dyspnea and orthopnea that started 1 week prior to the presentation. But she had the context of chest angina on exertion that was aggravated during the last period. Hypertensive, dyslipidemic as risk factors. Most important is that in 2016 she had biological aortic prosthesis implanted for severe aortic stenosis, which was normal functional at the moment. And at the same time, she had a right coronary bypass graft, venous one, for an ostial stenosis. At the presentation, she was in rapid atrial fibrillation. There was some slow R-wave progression in V1, V3, with minimal ST elevation in V3, V6, and negative T waves in inferior and lateral derivations. The colleagues did the echography. We have an ejection fraction of 28%. with ischemia with hypokinesia in the inferior wall and in the apical segments, and akinesia at the apex. Associated, there is severe mitral regurgitation with a moderate tricuspid regurgitation and high pulmonary arterial pressure. Biologically, the high sensitivity troponin was 160 and then got to 300. She has also chronic kidney disease and NT-proBNP is at 20,000 picograms per deciliter. So actually we're thinking that it's maybe not such a non-STEMI case, but a decompensation on an ischemic history. Nevertheless, we do the angiogram. And now we can see that there's severe stenosis and the left main circumflex LAD, ostial LAD with a lot of calcium. Not much to say, just a very, very bad stenosis with a TME1 flow in the LAD. And on the right coronary angiogram, we can see the ostial stenosis of the right coronary artery. In the mid segment, we can see there's a flow, competitive flow from the bypass graft. And then we inject the graft, and I'll let you watch it a little bit and see if you, maybe the more experienced ones know exactly what that is. For me, it was really a novelty. It was a little bit like that myth of the invisible ships that the Americans couldn't see when Christopher Columbus arrived in America because they were not used to seeing that, you know. So, well, actually, I'll try to get back. Sorry. I wanna play the movie again of the graft. If you can help me, please, with the. Okay. The second film, please. Yeah. The one on the right. Not working anymore. Okay, we'll see it. Yeah, we'll see it again. So actually, the graft was implanted on a marginal of the right coronary artery. So highly unusual, unexpected. And we can see that at the ostium of this little branch, there's also a stenosis. And regarding the diameter of the graft and of the right coronary artery, I think this is also significant. So it was my colleagues who tried to do the angioplasty of the LAD at the presentation. They tried to do it with the Pilot 50. They had difficulties in passing the guide wire. They passed through the subocclusion at the ostium of the LAD with degrading of the flow in the LAD in the diagonal. They couldn't get better than that. So they chose a Pilot 150. They took a 1.2 balloon for a little bit of support. And I was saying that we're a young center. We didn't have much materials, you know. We don't have microcatheters. We don't have extensions. We don't have other guide wires. We try to do what we can with what's at hand. So actually, because they couldn't get any better and because the flow was degrading, they decided to stop. They said, look, it's not acute. We should see how things are going. We should wait. So what's to be done next? Well, of course, we're thinking about the LAD because it's obviously the diseased artery, in this case, the culprit. But to have the LAD PCI, it would be great to have a coronary status optimization maybe before to see better the distality, which we can't as soon as we pass the guide wire. And also, I forgot to show you that there were a little bit of septal injections from the right coronary artery when we injected the right coronary artery. So a retrograde access might be discussable if that's the case. Of course, in another center, but. On the other hand, if we continue to pick on the LAD and we can have a hemodynamical deterioration with ischemia, generalized ischemia, and it could be very, very bad for the patient. So in my opinion, the answer to the question would be to do the PCI of the right coronary artery before going on with the left, you know. So for that, after a few days, I retook the patient. I went femoral, 6 French with the GR4. Pilot 50, I had a little bit of difficulty in advancing it, but it passed. And the lesion was uncrossable by 1.2 balloon. Of course, there's not much support, but I didn't want to use an AL or something else because it's really osteal. So. And then I had to think about how can I improve the situation. So no rotablation, because everybody I think is thinking that, but I didn't have that option. So I wanted to increase the support, and in this regard, I took a right radial approach with another 5 French GR4 catheter, and I went in the graft. And I tried to bring the guide wire from the osteal, through the osteal coronary artery through the graft to the 5 French GR4 from the right arm, and to trap it over there. But actually, you can see that the graft is very, very big in diameter of the ostium. So my chances of going from a big diameter to a small one were close to zero. Tried a little bit, didn't work. So I thought about maybe getting a little bit of stabilization with the catheter at the ostium. Didn't work neither. And then I tried an anatomical anchoring, just advancing the guide wire in the aorta, in the subclavia to get more pushability, but it didn't work. So I thought to myself that I should go backwards. So I brought the Pilot 50 through the 5 French catheter that was in the graft, and I brought it through the ostial right coronary artery, because the stenosis, of course, is very, very tight. And then you come from a tight diameter of the stenosis to the big diameter of the catheter, so it's much easier to go that way. So I brought it in the catheter, in the anterograde, let's say, catheter, and I trapped it with a 2.0 balloon over there. So now I've got the support, and I continued by doing a retrograde predilation with a 1.2 balloon, which we can see passes very, very nicely, slowly, taking care of not damaging the graft, of course. And it passed really nice in the stenosis. I dilated with the 1.5 balloon, then with the 1.5 balloon, then with the 2.5 retrogradely, and we'll see the result. This is how it looked. And then I went antigradely. I had to take another 2.0 balloon because it didn't, the 2.5 didn't pass. Then a 3.0 balloon, which I inflated at 24 atmospheres, and I had a satisfactory result with a little bit of dissection of the ostium of the LAD, which is why I chose to implant a drug-eluting stent right away, and I post-dilated it at 4 atmospheres. So, sorry, I'll go back, but I think the movies might not, yeah. So here's actually the final result. And the patient was doing well. Actually, she was doing so well that I think everyone in the Balkans recognized the cevapi that she was eating the next day, but against her spicy diet, the ejection fraction improved a little bit in a few days, as well as the mitral regurgitation and the clinical status. and she's ready to be brought for a dedicated session for the LAD, left main, and circumflex. And if you're asking yourselves how will we do that, there are friends in other centers where we can bring her and we can do more things that with more materials. As a discussion, after a PCI of a native vessel that was grafted before, there are some articles in the literature from Khaldun Al-Aswad and James Pratt, Simon Welsh, that actually if you have a TIMI flow more than 2 in the graft, it might be a good idea to consider to close the graft, because otherwise it might be deleterious for the native vessel, for the stent implanted. So maybe we'll think about that. We'll see how it looks when we do the next PCI. As a take-home message, we have to keep open to new solutions and idea, even when we're fed up with the case. And thank you, and also I'd like to invite you maybe to our congresses in Romania. It's really close, and we've got the CHIP Congress in Bucharest, and another one, a joint congress of electrophysiology and interventional cardiology in Iași, where I'm based. So, thank you very much for the invitation.
Nice case, demanding comments.
Very unusual.
This is the beauty of interventional cardiology.
Yeah, sure.
That needs invention of the people. And this is a kind of paradox, but young people, not biased by some habits, conventions, are able to do that. Great congratulations. Yeah. You did a great job.
Thank you.
I just
Some
have
remarks.
one question. Sorry. Do you did all these maneuvers with bare wires retrogradely?
I'm sorry?
You work retrograde, you placed the retrograde wire,
yes.
and it was bare one. You said that you have no microcatheter,
Yeah,
no
yeah,
over-the-wire balloons.
No, but it went easily. Frankly, it was. I was also lucky because actually the graft was in the marginal, and the marginal conducted the guide wire to the ostium, because of its departure from the artery. So,
Still, this was my comment that it is not a good option to traverse retrograde without a microcatheter.
To protect it.
Because in some manipulation, because you can have a tension on the wire, it can slice the ostium of the guide, the ostium of the subvenous vein graft, and even the vein graft. But otherwise, it is, let's say, reinvention of the retrograde technique of Cato from 2006.
Geoffrey Hartzler, the first retrograde CTO was done exactly in this way. However, from the graft to the LAD.
Exactly.
I mean, in this way, but reverse direction.
Exactly, because they didn't succeed at antegrade.
Exactly.
The
first retrograde case
it was even not a CTO, it was, I'm not sure it was a CTO. Anyway, there are some strict rules, and these rules are made for the security of the procedure. But great case, really.
And next time,
now you are ready for the...
Take extra support wire. I mean,
not in the
ask the hospital to buy.
You are ready for the retrograde of the LAD. Thanks.
Thank you.
Thank you.
The next presenter is going to be Dr. Mampech Mankau from Thailand. And hi, hello, Mai. You're muted.
How are you?
I'm really happy to see you. And we are expecting your interesting presentation. The floor is yours.
Thank you. And so please play about the video presentation, please. Hello everyone, my name is เหมือนเพชรเหมือนแก้ว from ธรรมศาสตร์ University Hospital, Thailand. Today is my great pleasure to join the Bacterium Bifurcation Club meeting, and I'm glad to share you my complication case. This is a 66-year-old female with the underlying disease of hypertension, dyslipidemia, spondylolisthesis, and sickle thyroid disease. And she has a history of non-STEMI with heart failure in June 2022. And at the time, we performed the angiogram, which showed 3-vessel disease. And the patient underwent the PCI to RCA in June 2022. She also had a history of contrast media allergy and atrial fibrillation. Her LV function is good. EF was 54.4%. And at this time, we plan to bring her for the stage PCI to LCX and LAD. Let me show you the angiogram. So the RCA show a patent stent, and from the left choric angiogram, you can see the severe stenosis in LCX, and at the proximal to mid LAD with the severe angulation. Here you can see the severe angulation from proximal to mid LAD with severe calcification. So my strategy is to do the POBA for the LCX first, and then proceed to the LAD. I plan to do the rotational atherectomy to this LAD lesion. And I want to put the workhorse wire down and to bring the microcatheter down to exchange for the rotor wire. But the Corsair Pro couldn't follow the wire. So I used the small balloon 1.25 by 20 millimeter spindle balloon to dilate the lesion, but the balloon was ruptured at 14 atmosphere and entrapped in the angulated calcified lesion. And the patient developed chest pain due to the flow obstruction, but the blood pressure was still good at this point. So my first plan is to advance a body wire into distal LAD and inflate a small balloon to free this entrapped balloon. However, wiring to the distal LAD was very difficult and unsuccessful due to the lumen obstruction by the trap balloon. Anyway, I can put a Geon black wire into the first septal branch, and then I put a 2O balloon and dilate the distal from the septal branch to the proximal LAD to free the trapped broken balloon. Anyway, multiple inflation was attempted, but ineffective to free the trapped balloon. And you can see that at some point, the wire went inadvertently to a small septal branch. And at this time, the patient start to develop severe chest pain and unstable hemodynamic. So I put in the intra-aortic balloon pump, and I changed my strategy. I cut the proximal shaft of the balloon, and I insert the guide extension catheter over the guide wire and the balloon shaft to close to the trap balloon, and then retrieval was successful by using a traction of the trap device. The angiogram showed good distal flow, but there was a septal perforation into the right ventricle and a loculated space here. So you can see the contrast straining here. And the bedside echo show no pericardial effusion, but there was a hematoma at the septum adjacent to the RVOT. but there is no RVO3 obstruction. And after retrieval of the trapped balloon, the patient has no chest pain and the hemodynamic was stable. There was no pericardial effusion nor sign of the tamponade. So at this point, I decided to continue the PCI by load ablation of this calcified lesion with 1.5 millimeter burr. After load ablation, the angiogram showed no progression of the hematoma and the patient hemodynamic was stable. So I decided to implant 2 DAS from the mid LAD to the left main, and my plan is to overlap the stent at the septal origin to decrease the septal flow. And after that, I did a KBT with 3.25 millimeter NC balloon in LAD and 3.0 NC balloon in LCX. And I performed the final pot with a 5 millimeter NC balloon at left main. And this was the final angiogram. There was still the contrast leakage into this loculated space, but there is no progression of the hematoma. And after that, we did the serial echocardiogram, which show no pericardial effusion, no progression of the septal hematoma, and no RVOT obstruction. And the patient has stable hemodynamic. So we plan to manage the patient conservatively. And the IABP could be weaned off in the evening of the same day, and NOAC was withheld for 3 days and then restarted. And the serial echo showed some flow, but the hematoma was stable. So I decided not to put the coil, but manage conservatively. And we admit the patient for a week, and we did the CT corollary 9 days after the procedure. And you can see that the size of the hematoma was 11 by 16 by 30 millimeter, and it was stable, and the patient had no symptom and stable hemodynamic. So this is the take-home message from me. The entrapment of the rupture balloon in the angulated calcified lesion is a rare but potentially a life-threatening complication. And various maneuvers can be attempted. For example, using body wire and the body balloon to free the entrapped balloon, or partial inflation of the body balloon distally, followed by a gentle withdrawal, or the twisting wire technique, or snaring, or surgical removal. And in this case, the guide extension catheter can be used to assist the retrieval of the trapped rupture balloon in the angulated calcified corollary lesion. And the septal hematoma could be managed conservatively if the patient was stable. Thank you for your attention.
Great case. Thank you very much that you share with us. Any comments, any questions?
Actually, that was an approach for the entrapment of burr. This is if you have an entrapped rod ablation burr. There is now, after pulling, ballooning, actually you applied the strategy for freeing the entrapped burr. Just the first balloon, proximal balloon inflation, parallel balloon to the entrapped burr, and then if it not work, cut the hub and insert the extension catheter and then pull.
And if it's not working, your scenario, scratch and go,
Yes.
dilate the
this is
subintimal
also
space, but it's really rare.
Sakakura described 2 cases with this one.
Yeah.
Call the surgeons.
Call the surgeons.
Call the surgeons if you have.
Okay.
It's a nice case, really. In fact, I think the hematoma was due to dilation of the septum by the wire, which was probably went with a whoop.
Yes.
Because if you perforate, the wire should go easily into the left ventricle and whatever it goes, and sometimes you can use it. And the issue, these things are happening with the retrograde access, especially tracking the septos. And the right thing to do is to just evaluate and follow up, because very soon this hematoma will be resolved and nothing will left. We had such 2 cases here in our hospital. The issue is when you have the hematoma and when it increases and obstruct mainly the outflow tract, mainly of the right ventricle, because the pressure there is bigger and this wall and this hematoma is pushed to the outflow tract of the right ventricle. And there is a solution there. You can go and puncture. In fact, go into the place and puncture with a PCI, CTO guide wire, very hard, through the hematoma and make a connection with the right ventricle and the hematoma just to drain it. Even you can go with a balloon, just probing without predilation, without dilating it. But this is the way to manage some of these cases.
Have you observed sometimes with septal hematoma conduction defect?
Not.
No.
But no. I think because in fact they are more deep, and in fact the conduction system, and that's the problem with TAVI. It goes into the septum, and after that it goes outside the septum and is traveling near the
it's more superior, subendocardial.
It is subendocardial.
It's subendocardial, and this hematoma is deeper.
The main issue is, yes, the main issue is how distally it travels and goes out from the septum. And that's something you cannot escape sometimes with TAVIs, nevertheless, how high you implant them. But that's another issue. Thanks.
Thank you very much.
Congratulations.
Thanks for being with us. Thank you, really.
Thank you so much.
Thank you.
So this is the end of our session. Hopefully the end of our course. Dobry.